So next we have Dr. Sonal Patel and Dr. Annique Hogan, who are going to be talking about the GI issues of GM1. So Dr. Patel, Dr. Hogan, please take it away.
Hi, thank you so much. Dr. Patel, I believe I saw your name on here as well. I just want to make sure your audio is working, and can you hear me okay?
Yes, it is, and nice to see everyone.
Excellent. So I'm Annique Hogan. I am at Children's Hospital in Philadelphia. So now if you want to say hello.
Sure. My name is Sonal Patel. I'm a pediatric gastroenterologist by training. I'm currently not practicing.
And I'm not sure who's advancing the slides. Excellent. So we are going to talk about the symptoms and causes of feeding difficulty in patients with GM1, talk about some various feeding tube options to consider, some really common GI issues that you'll see in this population of children, and then some methods to sort of optimize feeding intolerance and feeding difficulties in the face of pulmonary and neurologic comorbidities that can have a real impact on GI symptoms. Next slide. So you can continue on. All right. So just starting with the concept of feeding difficulty, and we're going to talk about some terminology here. So when we talk about feeding difficulty, this is really the larger, category or bucket, if you will, for a large number of feeding problems. So feeding difficulties can occur at any step of the game. So whether it be sort of the initial process of latching or drinking from a bottle, from a cup, the act of swallowing, food acceptance, chewing, or even how one tolerates the feeds themselves once they've actually been consumed. Advance. Keep going. All right. And so from a terminology perspective, I also want to talk about the concept of dysphagia. So this really refers to, and I want to introduce these terms, which you may have already heard before, but these are going to be things that you're definitely going to hear people sort of talk about, in terms you're going to hear used. So dysphagia is difficulty in or discomfort in the swallowing process, and it's really a symptom of something else that is happening with the body. And then aspiration is where we are worried now that you've inhaled contents either from the mouth or that has been refluxed up from the stomach into the airway and has gotten below the vocal cord. So we really worry about this getting down into the lungs. Advance. There we go. So when you think about sort of red flag signs and symptoms of feeding difficulty, so this is where we will see symptoms of choking, vomiting, bringing up food, coughing, gurgling. So that cough might sound kind of wet. You might hear some of those sounds when a child is eating or drinking. There may be some weakness. So some families may report this as it just takes longer to finish that feed. It takes longer to finish that bottle. They seem to need more breaks. You may see gagging, and this may be reported as sort of the sensation of food being sort of stuck in the throat as well for someone who's able to communicate about that. Or having difficulty sort of moving the food around in the mouth, being able to manipulate, what we call the bolus of food in the mouth. Babies might get really, really irritable at the time of feeding as well. Advance. So when you see any of these things, we really want to, sort of let that be a cautionary sign. So why are we seeing this? So anytime you have this degree of neurologic impairment, you're going to change important things that are involved in the act of swallowing. So whether that be the both voluntary and involuntary controls around swallowing. When we swallow, there's a lot of things that happen to help to protect our airway and to protect our lungs, so that we are sending that food or liquid down into the esophagus and into the GI tract, and not into down into the lungs. When you have any sort of neurologic impairment, that is going to be compromised, okay? You're going to have worsening muscle tone, and that's also going to affect the ability to not only feed and swallow, but also to move the feeds along the GI tract. You're going to have impaired refluxes and really changes in the child's level of neurologic functioning. Next slide. So it's important to really kind of think about when you're seeing some of these concerning symptoms that really show us we need to be worried about dysphagia, we need to be worried about a feeding difficulty. When is it time that we actually start talking about a feeding tube? And so to put it in the most simple terms, when you're no longer able to meet nutrition and hydration needs with feeding by mouth, or when there is a significant risk of aspiration. So that's when we start talking about feeding tubes. Next slide. And so we're going to talk about some options for these feeding tubes. So I'll start out with the more temporary options. So these are going to be our nasal tubes, either going into the stomach, an NG tube, or going into the intestine, which is going to be an ND, nasoduodenal, or NJ, nasojejunal tube. So an NG tube is one that we will use pretty commonly because it allows us to have the tube going in the nose directly to the stomach. We can teach families how to replace these at home. We can replace them. We can place them in the hospital. You can feed both as a bolus, which is, where you're giving a feed intermittently, the same way that the rest of us eat or drink intermittently, or you can run it at a slow drip, continuously. We really do think about how long someone's going to need to have a feeding tube when we think about using an NG tube, and this may be a bridge to the next step. Now, an ND or an NJ tube, so going in the nose, going to pass directly through the stomach and into the intestine, this is not something that we can teach a family how to replace at home. This has to be placed in a hospital setting where you can confirm its placement with an X-ray. You can only feed with a pump, so continuous feeds with a drip. You can have scheduled breaks, but you can't bolus past the stomach. But we would consider a feeding option like this in someone where there's, for a wide number of reasons, you can't tolerate feeds into the stomach, or if we are doing this potentially as more of a diagnostic measure. So we want to see how much is the stomach intolerance impacting how someone is tolerating feeds overall. If we want to see about taking reflux out of the picture temporarily to try to reduce variables when we're trying to solve a problem, we might use a tube like this. Next slide. Thank you. So our types of tubes, so when we're going across the abdominal wall, so we have our G tubes, which is a gastric tube that's going directly into the stomach, a J tube going across the abdominal wall directly into the jejunum, or a GJ tube, which is going across the abdominal wall into the stomach, and then on the inside, it's a longer tube that passes out the exit of the stomach, which is called the pylorus, into the duodenum and then the jejunum. Next slide. So I just want to kind of go through, these are the parts of the G tube because you become very, very familiar with this when this is a big part of your life. So this pictured here, the little one with the black background is called a button or a low profile G tube. And so we have the outer part, we call it the external anchor. That's what's on the outside of the body. The shaft is the part that is passing through the abdominal wall, and the bumper or the balloon is what's holding it inside. And so you can see a little cartoon image there that shows you in cross section what that would look like there, but that's with a non-low profile tube. Keep going. All right, so a lot of people ask, how do I wind up getting a button tube? And so it's important to realize that there's different types of tubes that you may start out with that are all G tubes. So you can get a PEG tube that's the short way of saying a percutaneous endoscopic gastrostomy tube. And that one, at least in my institution, is placed in interventional radiology, but sometimes it can be placed by gastroenterology or surgery as well. And that tube, the first one, is not going to be a little button. It's going to be a longer tube on the outside. But after the first tube replacement, you can wind up getting a button or the low profile tube. Or you can have your tube placed surgically by a general surgeon. And then the first tube might actually be a button. Or even if it wasn't a button, after that first tube change, you can get it changed into a button G tube. Next slide. And then GJ tubes. So the GJ tubes, as you can see here, they come in different options. Some are button or low profile, and some have a longer profile on the outside, so we can adjust the shaft or the part that's crossing the abdominal wall to have an adjustable shaft length. So the one that you can see all the way there on the left is one of our sort of non-low profile or the longer GJ tubes. And then the one in the middle, the AMT G-Jet, and the one all the way on the right, the Mickey GJ, those are both button GJ tubes. And what's important to know about the GJ tubes is that you have two tubes inside of there. One that's going to end at the stomach, but they are all sort of fit into one, and one that's going to continue out and go into the jejunum. Importantly, though, those tubes remain separate from one another the entire time. So that whatever you're putting into the G tube portion of that GJ is not mixing with whatever is in the J tube portion of that GJ. And then in recent years, we have a newer option that is really ideal for our smaller patients, those patients who are less than 10 kilograms in weight, and that's the AMT Micro G-Jet. So I use this in some of my really quite small patients whose bodies are not big enough for the other standard GJs that we have available in the market. Next slide. I'm going to hand it over to Dr. Patel.
Thank you so much, Dr. Hogan. It's such a pleasure to be here with all of you today. Just a little bit of background about myself. I'm a pediatric gastroenterologist, but I'm also the parent of a child with a lysosomal storage disease. So much of what I'll be discussing today is kind of a combination of my, sort of formally trained knowledge, but then also the knowledge that I've had and just gained over time in caring for my daughter. So first, what I'm going to do is sort of dive into some commonly encountered GI problems in patients that have GM1. And maybe being a pediatric GI, I'm a little bit biased, but I really do feel that managing constipation and reflux can potentially improve the quality of life for these patients significantly. So I hope this discussion will be helpful and beneficial in the care of your child. Next slide, please. So when we think about, go ahead and advance all the way through, please. Thank you. When we think about why constipation occurs in someone with GM1 compared to someone that doesn't, there are many potential reasons, but really 4 stand out in particular. So the first is poor gut motility. We know that the intestinal tract is supplied by a tremendous amount of nerve fibers and nerve endings, and these help the intestines sort of contract and relax and help those valves and sphincters contract and relax to help move along food. So that it eventually exits the body. But in conditions like GM1, where the central nervous system is affected, the function of these nerve fibers is affected, and this ultimately leads to difficulty with constipation, poor motility, and retention of stool. A second cause is suboptimal hydration. So water is essential to soften the stool, of course. And this makes it easier to evacuate if stool is softer. Now, some patients are unable to tolerate adequate amounts of water and fluid and require concentrated feeds. They may not be receiving enough water to help soften that stool. Additionally, poor control of oral secretions, fluctuations in body temperature, abnormal movements, and seizures can also lead to increased losses of water to the environment, which is what we call insensible losses, which eventually lead to a certain degree of dehydration and can contribute to constipation. As Dr. Iwanaga had referred to in his presentation, neuroscoliosis not only affects the respiratory tract, but can also affect the intestinal tract as well, particularly in patients that are non-weight bearing, and it can affect the bowel's ability to move. And then finally, decreased activity, especially weight-bearing activities, can be a major cause of constipation. So when a person is upright, gravity, of course, assists in helping those intestines move a little bit better and helps pull that stool down and out. And this is one of the reasons why utilizing equipment like a stander can be so incredibly helpful for patients to help with motility of their bowels. As opposed to someone who's, on their back or laying on their side for prolonged periods, it makes it much more difficult to pass stool. Next slide, please. So as I said before, decreased gut motility occurs in patients with GM1 because of their underlying neurologic injury. It's important to raise concerns to your doctor to consider a motility evaluation if, constipation and reflux management is really optimized, but patients are still having persistent symptoms of constipation and reflux. Some of the symptoms that might clue you in that your child may be having issues with gut motility include vomiting. Advance, please. And this can occur either with or without feeds. Emesis can be large in volume, it can be frequent, and it can be bilious, meaning that it contains a dark goldeny brown type of fluid that's secreted by the liver and the gallbladder into the intestinal tract. So you know that if it's coming into the stomach, things are actually moving backwards, and that can be an indication that there's something going on. Sometimes emesis can be large in volume and can happen hours after a feed. That's another indication that there's something from a motility standpoint occurring. And then from a constipation standpoint, if you're using a stool softener and a stimulant, but your child is requiring large amounts of these medications in order to pass a bowel movement, that might be an indicating sign. And then other symptoms, including pain, gas, and bloating. So air can become trapped in the intestines when there's a motility issue. And then retention of stool can also cause an increased production of gas. If you feel like this is an issue for your child, it's super important to vent their G tube if they have one, or vent their vent the G port of their GJ tube as well, just to help evacuate some of that bowel gas that can provide a substantial amount of relief. Next slide, please. So when we talk about management strategies for constipation, really it's kind of there's a two-pronged approach. There's the mush and the push. So the mush helps to soften stool, and we accomplish the mush by treating patients with osmotic laxatives. And these types of medications essentially bring water into the colon to soften the stool. Examples of these medications include polyethylene glycol. You may know this as Miralax. There's magnesium hydroxide, docusate, also known as Colase, and magnesium citrate. And magnesium citrate is easily recognizable at the pharmacy. It comes in a glass bottle, and it's usually flavored in lemon or orange or cherry flavors. So that's kind of how you know that's magnesium citrate. But these magnesium citrate is generally used for bowel cleanouts. Advance, please. And then there's the push, which helps evacuate. And this is accomplished by using a stimulant laxative. So a medication that helps the colon actually squeeze out stool. And agents that we generally use are Senna, which is also known as X-Lax. And then there's Bisacodyl, which is Dulcolax. Next slide, please. Sometimes, despite starting your child on, a regimented, sequence of bowel medications, they still become constipated for whatever reason. And you need to give them more. And some of the things that can be used include glycerin suppositories. These are inserted into the rectum, and it causes relaxation of the anal sphincters to allow for evacuation of the last portion of the colon. Advance. And then there's also Dulcolax suppositories, which are rectal stimulants as well. Advance. Actually, advance all the way through, please. Saline enemas can be used to help flush out that last portion of the colon. It's important to never use water for administration. If you are going to do an enema, it's important to use saline. And then sometimes we recommend a complete bowel clean out where we put patients on a clear liquid diet, and we have families mix larger amounts of polyethylene glycol with some sort of electrolyte solution, like Pedialyte, and then we can combine it with a stimulant medication like Senna or Dulcolax. But you want to always watch out for signs of dehydration because patients that are medically fragile can easily become dehydrated, and this is the last thing that we want to cause when completing a home bowel clean out. Next slide, please. our goal really is to have patients pass soft formed bowel movements every 1 to 2 days. So if you feel like your child is not, quite at that 1 to 2 day mark, is maybe going 4 or 5 days, definitely talk with your doctor to help formulate a bowel regimen that can be effective. Next slide, please. So moving on to causes of reflux, which is another symptom that can potentially cause issues in patients with GM1. So similarly to constipation, but just in the other direction, essentially, poor gut motility can actually cause retrograde or reverse movement of food or formula, leading to reflux or vomiting. Increased stomach gas can also cause belching and reflux. Patients may develop reflux due to an intolerance of one of the components in the formula they're receiving, or the food they're eating. They may not tolerate the volume of feeds that they're receiving. They may be being fed too soon after the last feed, or even too rapidly. And all of this is incredibly patient dependent. I wish there was sort of a recipe that we could provide families with to follow, but each child is different, and so much of this is trial and error. So I would encourage you to, kind of embrace that, and just know that just because one thing doesn't work doesn't mean that trying something else may not be beneficial. It's just a matter of trial and error, as I said. Next slide, please. So when we talk about medical management options for reflux, we sort of divide the options into the degree of symptoms. So if you have mild reflux, starting by eliminating potential food allergens or irritants might be a good place to start. Trying to find formulas that don't contain cow's milk protein, avoiding foods that are acidic or high in fat. So incredibly fatty foods tend to slow down gastric emptying. And so that might help with reflux if patients are eating less fatty foods. You also want to optimize the volume of the feeds. And if there's a way to concentrate those tube feeds down into a volume that's a little bit more tolerable, that can be incredibly helpful. Adding a thickening agent to a formula. This is particularly helpful for babies that are still being bottle fed. This just, it is sort of like it prevents things from coming up just because it's heavier and thicker. And then positioning adaptations is incredibly important to make sure that patients are not flat on their back when they're being fed, but are upright to a certain degree. And then with regards to moderate to severe reflux, this is when we start to discuss medications like acid blockers. So there's proton pump inhibitors, omeprazole or lansoprazole, histamine 2 receptor agonists like famotidine. These are agents that are going to decrease the acidity of the reflux and decrease the amount of gastric acid that the stomach is making. And there are surface agents like sucralfate. These agents coat the lining of the stomach and the esophagus so that the reflux is less irritating to the lining of the stomach and the esophagus. Interestingly, baclofen, which is a medication that many patients with GM1 are on, reduce the frequency of lower esophageal sphincter relaxation and can actually help with reflux. Next slide, please. Oh, I'm sorry. Last part. There are also motility agents that help increase the movement of food content through the stomach and the intestinal tract. These include agents like erythromycin and Reglan. Cyproheptadine helps the stomach to expand during feeding. And then there are anti-gas agents like simethicone. Next slide. And Annique, I'll pass it back to you.
Sure thing. So, really just to wrap things up, we also wanted to kind of bring it back to how do you kind of fit all the pieces together? So I'm a complex care pediatrician, and so my role in caring for children with GM1 is to help to fit together all of the various different issues and problems, because we know that we have amazing specialists in all the different organ systems, but our children have all of these things working together. And so how do we think about the influence, impact that different problems have on feeding intolerance? So next slide. So I want to draw your attention first to, your child's respiratory and pulmonary status. And this is where I think the talk that just finished on the respiratory considerations is so important. So when you have a child who has significant increased work of breathing, that's changing the pressure in the chest cavity. That's also then impacting the amount of pressure when you're having to work harder to breathe. You're using your belly muscles to breathe. That changes the pressure in the abdominal or the belly cavity as well. So anything that we can do to improve work of breathing will actually also help to improve feeding tolerance. It's also important to recognize that when your child requires non-invasive ventilation like CPAP or BiPAP, you're blowing a lot of air into the stomach. And so Dr. Patel already talked about, how managing that air can be a problem. And so when you're putting more of that air in there, you need to think really, really carefully about what you're going to do to try to allow that, that gas an escape valve. So this is where venting comes into play, right? You want to think really seriously about what the airway and pulmonary clearance regimen is. So how are we helping to mobilize those secretions? Because if your child has a hard time moving those secretions, then when they're trying to mobilize themselves and things are a little bit more weak, they're going to cough, they're going to have some choking. That is going to trigger those same movements that are going to not only bring up those secretions, but also trigger bringing up their feeds and have vomiting as well. And that's going to potentially worsen that risk of then aspirating what just came up. And then thinking about secretion management. So when you're really struggling to manage those secretions, and struggling to sort of have the airway sort of be protected from those, that can also affect those efforts to try to protect the airway, can impact feeding tolerance. Next. And then, there's lots of different things, but I just want to highlight these two categories of respiratory and neurological. So in children with GM1, you have significant impacts on muscle tone, both hypertonia, so high tone, and hypotonia, so low tone. You see a lot of that really high tone in the extremities and that low tone in the center, the central parts of the body. And so having that differential tone absolutely impacts feeding tolerance. Also, those episodes of dystonia, so those very specific episodes where the whole body just seems to be sort of tightening up in response to some sort of negative stimulus, those episodes can really significantly impact feeding intolerance. So when I'm dealing with a child who's having a lot of feeding intolerance issues, I'm looking at what else is contributing. So I'm going to work on how do we optimize tone? How do we help to take care of and treat episodes of dystonia? And then we have a lot of seizures that are happening. That's also impacting the respiratory status and it's impacting feeding. Next slide. So we want to thank you for your attention. I'll ask Dr. Patel to come off of mute as well. We look forward to talking with you in the question and answer section. Feeding intolerances and feeding difficulties are such a prominent issue, and I'm just so delighted to be able to talk with you with Dr. Patel on this.
Thank you, everyone.
Dr. Hogan, Dr. Patel, thank you so much for your expertise on this very important topic.